low rate of hematoma resolution. And surgical evacuation through bare hole or craniotomy remains as a gold standard treatment for symptomatic patients. However, high rate of recurrence, up to more than 30%, has been reported following surgical intervention. In the past several years, middle meningeal artery embolization has emerged as a promising treatment modality for patients with chronic subdural hematoma, both as an adjunctive treatment after surgical evacuation or standalone treatment. Regarding how middle meningeal artery embolization works in this setting, prior animal studies and microscopic evaluation have demonstrated that after initial hemorrhage in subdural hematoma, there is an inflammatory response starts, which includes the dural border cell layer proliferation and angiogenesis, which result in the formation of an immature and leaking capillary bed and a membrane around the subdural hematoma. This fragile vascular membrane serves as a source of progressive hemorrhage and therefore recurrent subdural in these patients. The middle meningeal embolization has been shown to perhaps decrease the rate of recurrent bleed, likely by devascularizing this subdural membrane and therefore breaking this vicious cycle of vascular proliferation and progressive membrane leakage. So some anatomical consideration for middle meningeal artery embolization. Every embolization case starts with careful angiographic review of the vascular anatomy. The most common configuration of the middle meningeal artery anatomy starts with MMA taking off from the proximal segment of the imax, as you see in this lateral view of the external carotid artery injection. You see STA, imax, and middle meningeal artery taking off. However, in rare cases, middle meningeal artery can originate from ophthalmic artery or rarely or directly from the internal carotid arteries. In those cases, embolization of the middle meningeal artery might not be safe for this purpose. So after identifying the middle meningeal artery, we do super selective microcastile injection of the artery. Here in this lateral view of the middle meningeal artery, you see the frontal branch of the middle meningeal artery and also posterior branch of the artery. There are two branches that we study carefully regarding the dangerous anastomosis. One is here, as you see the arrows are showing this haziness here. These are petrosal branches. They contribute to the facial nerve. So embolization proximal to this branch has the risk of causing facial nerve palsy. And here, when we go towards the frontal branch, you see this small branch going forward towards the eyes. So this is orbital or meningolacrimal branch. So again, embolization needs to be avoided in vicinity of this branch. So the safe embolization plan is to advance the microcatheter beyond these two dangerous anastomosis and carefully watch the embolization material and avoid any reflux to these two branches. In the past several years, various techniques has been utilized and described for subdural hematoma embolization of MMA. Majority of the previously reported cases is used PVA embolization particles. The advantage of these particles are they are inexpensive. They do not elicit any pain response. Therefore, the procedure can be done under max sedation. However, they are invisible, so it is a little challenging to see where exactly the small particles are going. They also tend to make clumps at bifurcations, therefore they may not necessarily fully penetrate the subdural membrane. The other embolic material which has been used are coil. Coils can be used for proximal occlusion of the main trunk of the middle meningeal artery. They're straightforward and fast to use. They're low risk because they're not gonna migrate or diffuse into the dangerous anastomosis. However, as you can imagine, we are not going to fully devascularize the subdural membrane, and the membrane itself might still continue to get blood supply from collateral circulation. And recently, liquid embolic material has been also used for this purpose, including onyx. So the advantage of using liquid embolic material such as onyx is it can be used through smaller catheter, which can be advanced more distal in the middle meningeal artery. They're easily visible, so we can see where the embolic material is going, and we can stop when we see it is going toward the dangerous anastomosis. However, DMSO injection is painful for the patient, and most of the time we need to do onyx injection under general anesthesia. And we can also use glue or NBCA, liquid embolic material for MMA embolization. Again, it can be used through smaller catheters. Glue is easily visible, and the advantage is it doesn't elicit pain, so therefore the procedure can't be done under max sedation. And these patients, some of them have multiple comorbidities, and general anesthesia might not be the most favorable plan for them. And similar to onyx, glue also offers permanent occlusion of distal middle meningeal artery branches. NBCA glue polymerizes when it contacts ionic substance like blood. It is typically mixed with a tidal to make it radiopaque, and also using a diluted NBCA will delay the timing of the polymerization. NBCA does not polymerize in non-ionic environment, so therefore the rate of polymerization, flow, and depth of penetration can be modified using diluted glue, as well as concurrent infusion of D5 in water solution. This technique has been previously utilized in AVM embolization or dural AV fistula, and is called sugar push technique. So we hypothesized that if we advance the microcatheter very distal in the frontal or posterior branch of middle meningeal artery, and while injecting diluted glue, the second operator start injecting D5 in water, that will provide the glue, the environment that will go further distally into the middle meningeal artery branches and fully penetrate the subdural membrane. We started this technique in 2019, and here we are reporting our experience regarding safety and efficacy of this technique for this patient. We reviewed our prospectively collected institutional database and identified all patients who underwent middle meningeal artery embolization with this technique during 2019 and 2020. Inclusion criteria was age 18 or older, chronic or recurrent subdural hematoma, and middle meningeal artery embolization using diluted glue with sugar push technique, and presence of follow-up CAT scan at 1 week and up to 6 months after intervention. In terms of the technique that we used, Triaxial system was used in all patients. This is the lateral view of external carotid artery angiography. Here, down here, you see the guide catheter. It's been part in the proximal segment of the ECA. And then up here, the arrow shows the intermediate catheter, which is like at the origin of the IMAX. And after we advance the microcatheter up to the either frontal or posterior branch of middle meningeal artery, the intermediate catheter will further advance into the origin of the middle meningeal artery to effectively arrest the blood flow to the artery and then maximize the impact of D5. While the first operator is injecting NBCA through microcatheter. The second operator injecting high volume D5 through intermediate catheter via 60 cc syringe to clear the MMA from the blood and provide this non-ionic environment to NBCA, so it will go much distally. In cases where the distal catheterization of the middle meningeal artery was not possible due to tortuous anatomy, we decided to put some coil and just close the proximal segment of the middle the artery as a rescue plan. So our outcome measures included primary efficacy outcome, which was the rate of recurrent symptomatic subdural hematoma, which required surgical evacuation. Imaging efficacy outcome included complete or near complete resolution of hematoma, which near complete defined as 90% or greater decrease in the size of the subdural hematoma in 6-month follow-up scan. And primary safety outcome defined as the rate of cranial nerve palsy or thromboembolic event resulting in TIA or stroke, and also access site complications such as hematoma or ischemic complications. We also define angiographic outcomes as the rate of subdural hematoma membrane penetration by blue, the rate of NBCA cast reaching the midline in the AP view, and also the rate of the time that NBCA cast crossing the midline to the contralateral side. So we identified 61 patients during this time period, which were being treated by this technique. The mean age was 62. 78% of them were male. Their initial NIH stroke scale score was 1. 25 patients were on antiplatelets and 9 patients were on anticoagulants. Totals of 22 patients had bilateral subdural hematoma. 49% of the patients had surgical evacuation using either craniotomy, burr hole, or sepsis prior to embolization. The embolization procedure was performed through radial access in 29 patients, almost half of the patients, and under max sedation in 64% of the patients. Complete closure of both frontal and parietal branches of middle meningeal artery was achieved in all cases. Of note, in 6 occasions, we had to use coil embolization to take the trunk of the frontal branch of the middle meningeal artery because the distal catheterization of the branch was not possible due to tortuous anatomy. In 84% of the patients, the NBCA penetrated to the subdural membrane. In more than half of the patient, it reached the midline, and in 1 out of 4 patients, the NBCA cast crossed the midline to the contralateral side. This is an example of one of the patients, 71-year-old gentleman who presented with recurrent left subdural hematoma, as you see on the left side CAT scan. He underwent middle meningeal artery embolization using diluted glue. As you see here, the arrows are showing the glue cast in the frontal and posterior branch of middle meningeal artery. Here in the middle of the scan, you see the 1-month follow-up, and on the right-hand side, you see 6-month follow-up, which is showing near complete resolution of subdural hematoma. We'll be showing some examples of our cases here. On the left side, you see super selective angiographic run of the main trunk of the right middle meningeal artery, lateral view. Here is the tip of the microcatheter. Obviously, injecting glue from this position is not safe, as we see the petrosal branch and also collaterals to the eyes. So we advance the microcatheter up to much distal location in the posterior branch of the middle meningeal artery, as you see in the right-hand side, with this arrow showing the tip of the microcatheter. And at this point, this is safe to start a glue injection, as you see in the middle of the picture. And BCA injection is being performed. And glue is crossing the midline to the contralateral side. And we are way higher than any dangerous anastomosis in the petrous bone or toward the eye. Another example on the left side, you see super selective angiographic run of the frontal branch of the middle meningeal artery. The arrow points the tip of the microcatheter, again, way higher than any collaterals to the eyes. And you see some blush towards the subdural membrane. On the right side, you see the actual NBCA injection with sugar push technique. And you see how diffusely the glue is filling the entire branch and crossing to the contralateral, the meningeal artery branch. Another example, super selective angiographic run of the frontal branch of the middle meningeal artery. Again, the arrow is showing the tip of the microcatheter way higher than any dangerous anastomosis. And on the right side, you see the actual glue injection taking the total dismantle of the MMA membrane, the subdural membrane. This time, super selective angiographic run of the frontal branch of the left middle meningeal artery. Arrow is showing the tip of the microcatheter. And you see the membrane blush in this patient with left subdural hematoma. And on the right side, you see the glue injection. Sorry. You see how the glue is painting the entire branches of the frontal branch and also crossing to the contralateral side. Very safe. With this technique, there is almost never reflux to the proximal anatomy because there is a heavy sugar push providing the environment to the glue to go forward. In fact, sometimes we see that the glue is going too far because frontal branch of middle meningeal artery can go to the anterior falcine artery, which actually can go down to the ophthalmic artery. So what we watch here is just to make sure glue doesn't go too far. So all patients underwent post-embolization Cat scan at 1 week and 1 month, and 86% of the patient had 3-month follow-up scan, and close to 40% of the patient had follow-up scan at 6 months. So we encountered 3 patients with recurrent subdural hematoma, which is 5% of the cases. One of these patients had a new subdural hematoma at the contralateral side at 6-month follow-up, who underwent NBCA embolization of the contralateral side and remained stable at 1-month follow-up. The other 2 patients had worsening mass effect from their known subdural hematoma after MMA embolization during the hospital stay, and they underwent craniotomy and verhole placement or verhole placement for hematoma evacuation. Of the 23 patients with follow-up scan at 6 months, 96% had near complete or complete resolution of previously known subdural hematoma. Regarding the safety outcome, no cranial nerve palsy, vision loss, or ischemic stroke was seen in our cohort. Again, the distal positioning of the microcatheter and using diluted glue with sugar push technique made the procedure extremely safe, and the rate of cranial nerve palsy or vision loss 0. One of our patients, though, had a transient episode of altered mental status and slurred speech after procedure, which resolved following in few hours. And regarding the access site complication, one patient had growing hematoma, which was managed conservatively with no intervention needed. So our cohort is the largest series to date of MMA embolization for subdural hematoma using NBCA. In this cohort, we demonstrated that diluted NBCA with simultaneous large volume D5 injection result in more distal and diffuse penetration of NBCA to the subdural membrane. It can be performed under max sedation and via transradial access, as half of our cases were done through this access. The point here is using this technique, we can offer meningeal artery embolization as an outpatient procedure. Patients come to get the procedure done under max sedation through radial access. We'll go back home same day, back to normal life from next day. The recurrent rate in our cohort was 5%, which is comparable to previously published studies. And as mentioned, there's no procedure-related vision loss, cranial nerve palsy, or stroke encounter. So we believe that unlike particles, NBCA permanently vascularize the target vasculature, therefore provides a more durable benefit. And also with direct visualization of the embolic agent, as you saw in the prior slide, it's easier to control the depth and distribution of the embolization and avoid reflux into dangerous anastomosis. Also, distal and more diffuse penetration of the membrane can be consistently achieved with this technique. Some of the limitations of our studies, approximately 20% of our patients did not have 6-month follow-up clinical or CAT scan. Therefore, the cautious interpretation of the long-term benefit of our proposed technique is warranted. And also, although a very high rate of technical success in this comprehensive devascularization of the MMA vasculature was achieved in our cohort, whether this technical approach has any superior benefit regarding outcome in decreasing the rate of recurrence of subdural in comparison to other techniques such as particles, coils, or onyx, needs to be studied in randomized clinical setting. Regarding the future directions, we are in process of proposing a standardized grading system for middle meningeal artery embolization using liquid embolic material, which can be glue or onyx. We believe this standardized grading system will help us to further understand the clinical and outcome significance of deep penetration of the embolic material and comprehensive vascularization of the MMA branches in this patient. This grading system is from 1 to 5. 1 is when there is just a proximal ligation of the proximal trunk of the middle meningeal artery, similar to what we can achieve with using coil. 2 is when the branch penetration occurs without reaching the midline. 3 is when the branch penetration with the embolic material achieved, and also the embolic material reaches the midline. 4, grade 4 is when embolic material crosses the midline to the contralateral side. So this is 1 to 4. And if there is a subdural membrane identified during the microcatheter injection, and if there is a membrane penetration of the embolic material, that injection will get extra point for that. So most of the injections that I showed you, they will qualify to either 4 or 5 grading based on this grading system. We are in process of finalizing this grading system in 100 consecutive patients that we have done here at Sinai, and we'll be finalizing the manuscript in the near future. And also, we are participating in 2 ongoing randomized clinical trials. One is membrane studies, which is middle meningeal artery embolization for the treatment of subdural hematoma with NBCA. And this is a multi-center randomized clinical trial. Dr. Kellner is one of the national co-PIs for this study. And also there's another trial called Embolization of the middle meningeal artery with onyx for subdural patients. So I believe these two clinical trials will have significant importance in terms of helping us to study the actual benefit of middle meningeal artery embolization in subdural hematoma patient, as this study has the medical management arm, surgical intervention arm, plus or minus embolization. This will also give us the opportunity to compare the outcome of using liquid embolic material in the subdural hematoma embolization to the historic database of using particles. I think that's, I'm gonna stop here and take questions.
Hey,
Thanks
nice
a lot, Shahram. Oh, there you go. I was going to say, we'll see if anybody has any questions.
Nice job, Shahram. That was a really cool presentation, and I appreciate you doing that for us. A couple questions, actually. So when you look at the recurrent subdural hematoma patients, and the percentage is quite small, which is nice, do you see recanalization of the middle meningeal artery? I mean, has that been looked at by you guys or others?
So that's a good question. This has been shown with the particles and coils. However, we haven't seen precannibalization after using the liquid embolic materials. In fact, I do recall a case of recurrence. This was out of this database that came to me, and I did a second embolization. In the second embolization, those middle meningeal artery branches were gone. There was no collateral formations. However, I did the contralateral middle meningeal embolization for that patient. So recanalization can happen with the collaterals, but those branches that we take with glue or onyx, they will be gone permanently. That's why the case that we are making more diffuse and comprehensive devascularization of the membrane with permanent embolization material like glue might have advantage of avoiding any recanalization.
Do you think, so along those lines, I was going to ask you, why the liquid onyx versus the particles, and the images you showed us, the particles seem to travel further. Does the liquid, the onyx, kind of doesn't migrate that far? Is that kind of the impression? Is that a correct impression?
Well, onyx can also go further. We have different dilution of onyx, two types of onyx, 18 or 34. And there are some techniques that we can use and facilitate onyx going a little further with particles also can be used for deep penetrations. However, the disadvantage is, number one, we really do not see the actual particles. That's why we mix the particle with some contrast, so we see where the actual fluid is going. And we use different sizes of particles. Smaller particles can go much deeper into the membrane of the hematoma. However, using the particle, again, there is risk of recanalization. It's not going to cause permanent occlusion. And number two, as I mentioned earlier, they tend to make some clumps and they aggregate, and they may actually occlude the bifurcation before reaching the actual membrane of the subdural.
Thank you. Good job.
Thanks, Shahram. That was an awesome talk. I really enjoyed it. Just had a question relating to the use of the embolic material with the chronic subdural membranes. So the membranes can be very difficult or frustrating to deal with when you're trying to do an evacuation in the operating room. I was wondering if, given your scale that you showed, is there any data to suggest that the spread of the embolic material when it reaches, or you're seeing spread to the chronic subdural membranes, are those patients having better outcomes than when they aren't reached, or there's not spread there? And conversely, is the spread of the embolic material to those membranes causing significant regression of the membranes, or is it just observed that the overall subdural gets smaller?
Yeah, exactly. So this was a theory and hypothesis that we had. If we do a diffuse penetration of the membrane, theoretically, we devascularize this immature capillaries, and it may help with decreased rate of recurrence. The data in this area is still evolving. We do not have definite answer. However, in past few months, there was data came from Darrow. They actually demonstrated in their database that more deeper penetration of the embolic material, more diffuse embolization, and distal penetration of the branches been associated with lower rate of recurrence. We need a larger database to show that, but the evidence is starting to appear there.
Thank you.
Thanks. Just had a comment or a question. Shahram, great job. Thank you for presenting that. And one thing to respond to Dr. Hajipanias is I actually have had the benefit of seeing the MMA after tumor embolization. And I've seen that in some cases of onyx that sometimes there are little channels that that blood still kind of seeps through. So it doesn't, you know, maybe for some reason these tumors, they have a more hypertrophic MMA or something like that, but definitely see a little bit. So maybe it thromboses over time, like you said, but I've definitely been able to see it from the other side, which is, I think it's kind of interesting. My question is, you know, when you do these cases technically, are there any indicators for you that there's going to be a higher level of success? And I guess it kind of goes to Trevor's question. But I remember we had talked a while back about seeing the glue cross the midline was one thing that may be suggestive of success. But have you noticed anything else that may correlate, or is it just too soon to know?
Well, again, we don't have actual data to support that. But when we do see the plushy membrane, leaky membrane in the microcastile injection, and that followed by glue penetration into that membrane and crossing the midline, that's the sign that we think that we really are taking down this supply to the subdural membrane. Again, the thought is that will help to decrease the recurrence rate. However, we need a larger database to actually show that. As I said, we can use coil to take down the trunk versus use the aggressive embolization with this technique that I described. Probably this is superior to that, but we need to wait for actual data. Similar to what we see in the tumor embolization. Sometimes in tumor embolization, when we are facing a dangerous anastomosis, like in neuromeningeal branches or sending pharyngeal, sometimes we opt to just coil the feeding artery to the tumor versus using liquid embolic material. But then in follow-up MRI, and also when we follow up with the surgeon later, after using coil, there is still significant blood supply to the tumor from other collaterals. So the same concept, I guess, work here if we only take the trunk of the MMA to do proximal embolization. The membrane itself, that leaky membrane still will get the supply from the other collateral circulation. The other concepts that we are working on it, again, we need more data, is to perform bilateral middle meningeal artery embolization, even in patients with unilateral subdural hematoma. And again, the theory is with bilateral embolization, with the embolic material crossing the midline to the other side, you're basically providing a comprehensive takedown of the middle meningeal artery branches and collaterals, and that potentially will have further outcome benefits. Again, you need to wait for larger database to prove that.
Yeah. Yeah. And last kind of add-on question is, have you used any adjuvant devices like balloons that can help achieve those technical results, or is that also still kind of limited? I guess the question is, do balloons matter to control the flow or anything like that?
Balloon does matter when we are using onyx. So for onyx, we have a small balloon guide microcatheter. We inflate the balloon, and then that will help inject the onyx, and onyx will go more distally. With this technique, sugar push technique, no balloon is required. As I showed you, we can consistently achieve very distal embolization using this technique. By the way, our results are being published in Red Journal of Neurosurgery next month. It is in press.
Thanks.
Thank you. I think Jorge had a question.
Yes, thank you, Dr. Majidi. Very, very nice presentation. My question to you is, there is a recent study showing the cost effectiveness, achieved with middle meningeal artery embolization for these patients borehole evacuation. My question to you is, where does the diluted glue sugar push technique, stand in terms of how much does it cost for the patient compared to maybe onyx or coils or particles, and maybe even surgical approaches? Open. Thanks.
Great question, Jorge. Well, the surgical evacuation sometimes is inevitable, independent of cost. So symptomatic patient are gonna need surgical evacuation no matter what. But regarding the cost effectiveness, that's a great point. So onyx and glue, they are much more expensive compared to particles. So therefore, it will be very nice to have a head-to-head analysis of these techniques and should see if it is really superior to particles. However, we believe that with NBCA not being painful for the patient, easy procedure under MAC, we can offer this procedure under outpatient fashion. The patient comes, no need for hospital stay, will go home same day. That might offset some of the costs.
Awesome, thank you.
And Shahram, we also have a question in the Q&A box. What is the mechanism why the chronic subdural hematoma does not reaccumulate in 90% of cases after drainage?
Well, again, the mechanism of the recurrence, as we know from the prior experimental studies, are just this membrane development and the immature neoangiogenesis. In some cases, it does not. So perhaps inflammatory process is not as robust as other patients. And also sometimes the middle meningeal artery is being taken during the surgical evacuation. That might also contribute to the lower rate of recurrence in those patients.
Okay. Thanks very much, Shahram. I don't see any more questions. So I think we'll wrap it up. Thanks, everybody.
Have a good day.